Okay, welcome everyone. Thanks for sitting through those presentations. I am joined here now by Dr. Gleason and Dr. McCann, who presented some tremendous cases. We've got about 10 minutes for some discussion and answers to some of the questions that came up in the chat. Perhaps one of the first things I'll start off with, if you guys don't mind, is to talk about the polling question that I inserted. I came up with that question after you guys did glaucoma cases that had some retinal disease. So I thought I'd try to poke the audience a little bit and see how often they are finding some type of retinal pathology in their glaucoma patients. And obviously a lot of little nuances in there, and it depends on how I write or you read the question. But the answer basically was that 57% of the audience said that 50 to 79% of the time they're finding some type of retinal pathology. That would actually, with 5% saying 80% or more of the time. So 62% a majority of the time. Any comments about that? Wes?
Sure. I think it's how you approach managing your patients as well. When we look at when I do an OCT, I'm usually planning to do an OCT based on my disease analysis of the patient and my DFE and any sort of retinal photography. At that point, I'm deciding, do I need an OCT and for what pathology am I looking at? So I'm not oftentimes surprised by other retinal pathology that exists when I do see a glaucoma patient. Usually I'm pretty sure I already know what that's going to be when I look at it on an OCT. The occasional time you'll see something like VMT or VMA, but I think back to will really change my management plan if I pick up something like VMT or VMA on that OCT. And if I do pick it up, likely not going to change my management plan, so wouldn't affect too much how I would approach that patient.
I guess, Sarah, the key thing is being able to differentiate glaucoma stuff versus retinal disease,
Mhm.
and that can be tricky, right?
Yeah, it can be extremely challenging. I mean, in my glaucoma clinic, I see a lot of degenerative myopia patients, and it's almost impossible sometimes to differentiate those changes. The macula scans are abnormal, the RNFL scans are abnormal, visual fields are often abnormal as well. So I think being aware of the concurrent pathology that your patient may have and keeping that full clinical picture aware and never looking at an OCT in isolation. You have to examine the patient first and be aware of the full clinical picture because sometimes it can be quite difficult to differentiate these different pathologies.
Yep. I mean, we have a tremendous tool with our OCT, and it can do so many different things. There's so many different types of scans and scan patterns that are best for certain diseases and conditions. And it's, sometimes I think it's finding the right tool for the right condition or the right scan pattern, and then knowing, how to make that interpretation of the OCT results. And of course, as you guys know, not everything red is real disease.
Mhm. Yeah, absolutely. I think especially in managing glaucoma, we have time with these patients, so we don't always need to immediately come up with a treatment option. So if we see something that's abnormal, sometimes it's okay to have an abnormal scan, and what I really will wait for in these cases is to see progression. Now, some of these conditions can also progress, like myopia, for example, or other retinal conditions, but I think kind of taking the full picture into account and waiting to determine if it's progressive pathology is so important in these cases.
Yep. And Sarah, there was a question about ganglion cell loss and when that occurs in the timeline of the pathophysiology of glaucoma and what our OCTs show us and what they can't show us. You want to tackle that one for me, please?
Yeah, absolutely. I think when, we think about a textbook answer and the pathophysiology of the disease, yes, that is what we would expect to see first is maybe changes in our ganglion cell. However, as, we learned through this lecture series and as we're discussing now, there are a lot of artifacts that we have to consider. And sometimes we have to also realize the capabilities of our instruments as well. OCT is amazing and it's really changed the way that we practice, but it's just one tool in the toolkit. And so I never look at a ganglion cell analysis alone. It's always in coordination and collaboration with the retinal nerve fiber layer analysis. And so I always think about structure correlation. Do those two scans make sense? And do things correlate between those two scans? And then, of course, structure function correlation as well.
Yep. So, for me, if I'm not seeing RNFL loss along with that ganglion cell loss, I'm really questioning whether or not that's true just glaucoma by itself.
Yeah.
I'd have to have other significant clinical findings for me to think that that is early glaucoma, because that's just not typically what I see. It certainly can show up there, but I think there's a correlation, as you said there, with the other retinal nerve fiber layer loss.
Yeah,
And I think it's
absolutely.
important not to jump too fast on it too, because again, like you were saying, even if you have some NFL loss, are they highly myopic? And is it red disease? Like, what are we looking
Yep.
at? And
Yep.
how does everything add up together? What are the pressures? What are the fields? What other comorbidities are going on, like we mentioned, and make your clinical decision on that. Again, I kind of educate my patient, like you said, Sarah. It's all about change, and if we're not changing, we're in an okay spot. And so let's follow you closely and make a good clinical decision.
Yep. Wes, I don't know if you were able to see the question in the chat about target IOP for your patient and setting them and putting that in the chart. And I know you made some comments in your presentation about that. I actually have I'll give you an advance warning, a little bit of a different opinion, but
Sure.
why don't you just touch on that for another minute or so, and then we can debate that a bit.
Sure. Like I think it's important to have an idea of what you want your target pressure to be. For sure. I'm not saying don't have a target pressure. I'm saying be cautious if you have a target pressure and you're not meeting that target pressure, but you're monitoring that patient, you might put yourself at risk.
Yes.
So be
You should
cautious
change
of
it.
it. And you may, and if you're going to record a target pressure that's not attainable and that patient's not progressing, what sort of risk are you putting yourself at? So I think it's important to have an idea of where you want that pressure to be your target pressure. But be cautious of how aggressive you are if you're going to report it in your chart, and ensure that you're documenting sufficiently to show that you might adjust that based on what your outcome is based on how you've treated that patient. So
Right.
and just be cautious on how you're reporting it is more what I was trying to say, and
Sure.
ensure that you're not ignoring the fact that you put a target pressure and then you're watching it without adjustments.
It is definitely a dynamic thing.
Yes.
It's not a static, it changes over time. It can go higher or lower. Sometimes we want and need 50% IOP reduction, but we can't get that. And so we have to make things that are reasonable and attainable. There's costs and benefits. If the patient really needs that and we need to think about surgical options or other things, that's fine. But I think you're right. But I agree, as you reaffirmed, having a target pressure and working towards that and knowing what our significant pressure reductions are is really important overall. So there was another question regarding the new reference database for the Zeiss Series 6000 OCT that came up that I referenced in my talk. And that was about the breakdown of racial population within the database. So it's about 55% Caucasian, 18% Black African American, and about 18% Asian. So that's for the FDA, for us here in the US, that's reflective pretty much of the US population. And that's how the FDA is looking to do these things today. I don't think there's ever going to be a ethnically or racially specific database for OCTs. It just is not practical. And, we have to interpret these all in the sense of, there are always going to be individual outliers. And many times, particularly for a disease like glaucoma, we have to wait for change over time to prove that analysis for us.
Yeah, absolutely.
Yep. So go ahead, Sarah.
Oh, no, I was just going to add too that, if you are following these patients over time, you kind of set your patient as their own baseline as well. So then you get away from,
Yes.
Of course, the normative database is so important initially, but having multiple scans, good, reliable scans, and then you kind of look for deviation from your own patient's baseline. And that's really where glaucoma management lives.
And it goes back just to what you said earlier, which is you have to be a little bit patient with glaucoma because it's not a fast moving disease and you have time. No
Absolutely.
one, very, very few, if any, patients are going to go blind, as you monitor them for a year or two. And if you don't initiate treatment right away, assuming the pressure is not exorbitantly high or whatever, it's okay. Get good quality OCT. So that's what we're going to wrap up here in the last 2 minutes, which is one or two quick pearls for using your OCT for the audience. Wes, let's start with you.
So we have the same workflow. So I'm in private practice, so efficiency is very important. So we have the same workflow for any time we ask for an OCT. So the same scans get done for every patient, whether it be ganglion cell, RNFL, same progression analysis, raster and radial, etc. So we have the same pattern for every single patient. So no matter what, I don't have to continuously send that patient back for additional scans, angles, etc. So we want to make sure that we're being consistent, and it makes sure that it allows us to ensure that the mistakes aren't getting made and things aren't getting missed. And it really improves efficiency overall within our practice.
Right. Sarah, what's your tip?
Yeah, one quick clinical pearl. It doesn't apply to every patient, but if you have a patient that is highly myopic or a keratoconic patient, for example, imaging them through their contact lens will often yield much better quality scans than without their lenses, especially for their regular cornea patients. So that's a nice tip.
Yep. And I'm going to cheat a bit and say, while using your OCT is essential, you still have to use your perimeter. So you mentioned structure and function before, and when things are not making sense on the OCT, go look at the visual field. I know patients don't like doing visual fields, but they can do them, and there's many ways to do faster visual field testing. So as we wrap things up here, I want to thank Drs. McCann and Gleason. You provided excellent cases and so many teaching points for our audience tonight. I thank everyone at Eyes on Eye Care and for Zeiss for sponsoring this wonderful symposium this evening. Thank you, everyone.